Good morning, everyone. Welcome to the Grand Rounds International Talk for Health for the World. It's 10 a.m. here in Durham, North Carolina. My name is Mohammed, and I'm one of the radiology residents here at Duke University. I'm really excited for today's talk. It is our residency program's first collaboration with this amazing organization that provides free radiology education to radiology residents and radiologists all over the world. And so that's really exciting and something I'm really proud of. I'm also really excited to introduce our first speaker from Duke who's collaborating with Health for the World, who is Dr. Kevin Kalisz. Dr. Kevin Kalisz went to medical school at Northwestern and completed radiology residency at Case Western University in Ohio. He then came to Duke University for abdominal imaging fellowship and did a second fellowship at Northwestern for cardiovascular imaging. And then we were very lucky to recruit him back to Duke University, where he is dual appointed in the abdominal imaging and cardiovascular sections. He's a beloved attending here at the radiology program and is an excellent educator and most recently won the faculty teaching award for the residents. And he'll be talking to us about cardiomyopathy and their imaging appearance on MRI. So it should be a really exciting and good talk. So Kevin, whenever you're ready, go ahead.
Wonderful. Thank you, Mohammed, for the very kind introduction, and thank you for Health for the World for allowing me to speak today. Hopefully, this will be kind of the beginning of a great collaboration and education from our institution. So as Mohammed said, I'll be talking about overview of cardiomyopathies at an MRI. It's really titled here a case-based approach, and that's really what this is intended to be. It'll just be a lot of illustrative cases. So just formally, what we'll do today, develop a basic approach to building an effective and efficient protocol to evaluate cardiac pathologies. And again, really the focus here is to illustrate the spectrum of relatively common, either commonly seen or kind of commonly tested for cardiomyopathies that we typically see at cardiac MRI. I'm not going to go too much. I'll do a little bit of introductory material in terms of a basic protocol and basic sequences. Unfortunately, that would be at least one, probably even more lectures to go through kind of the full protocol and how they work and how they're analyzed. This is the potential complete cardiac MR exam. We have a lot of potential options. I would argue more so than a lot of other MR subjects, whether musculoskeletal, neuro, or abdominal. Again, you can kind of see the potential options here and the relative flow, how they would come in the course of the exam. Again, some of these are optional, some of the order is even optional or debatable, but just keep in mind, if you really want to do everything at your disposal for cardiac MR, we're talking upwards of 90 minutes. So we really have to choose and choose wisely. Again, I'll just go over a couple minute overview of some of the sequences. We'll obviously illustrate over the course of the lecture, reinforce how these look and kind of how they're useful, especially in cardiomyopathy assessment. So really, with any sort of MR exam, even outside the heart, we get scout, and typically we get large field of view images. Of course, the scouts are for planning cardiac planes and subsequent sequences. And the large field of view images are really good for a thoracic overview and incidentals. I use the word incidentals here, but sometimes it's more than incidentals. It's really supportive to the diagnosis of what's going on with the patient. Cine SSFP, or at steady state pre-procession. This is really one of the most important sequences and really kind of the workhorse of your cardiac MR exam, no matter what it's being done for. From this, we get chamber function, a lot of the quantitative parameters that we get at cardiac MR, volume and mass, and thickness. We can do some qualitative evaluation, particularly the valves. We're not going to discuss too much of valves here, but we will touch a little bit on it, but we can get qualitative information about valves. Phase contrast is also very useful, like we see here on the bottom right. This is where we get a lot of the quantitative flow information, so velocity and pressure gradients, quantitative valvular function. We'll touch a little bit on this here, at least one pathology this is relevant. Ideally, you can also do shunt quantification here, but we won't be really delving into that today. One thing that I'll try to illustrate, this is a little bit newer kind of in the spectrum of cardiac MR sequences, the concept of multiparametric mapping, or T1 and T2 weighted mapping. So this, in terms of T1, for which you can derive extracellular volume fraction or ECV, that can be a quantitative marker of myocardial fibrosis. Similarly, you can also get information about potential infiltrative diseases from that. T2 mapping really assesses for edema, and we'll see a couple of applications of that today. And then T2 star is really important for iron assessment. MRA is a potential component of a cardiac MR exam. I have that here, and I've kind of mentioned that just for completeness sake, but I don't think I'll be showing any MRA images in our talk today. Stress and rest perfusion is obviously very important. Basically, the MR way to do stress test, and it's very important for myocardial ischemia, among other applications. And then delayed enhancement. So I mentioned from a structure function standpoint, the SSFP, the Cine SSFP images are essentially your workhorse. But delayed enhancement, I would argue, is the second most, if not the most important part from cardiac MR. And this will give you a good look at scar pattern, basically the ability to differentiate ischemic versus non-ischemic patterns. And if you do have an ischemic injury or kind of an infarct pattern, the concept of viability, which is generally defined as kind of the probability of functional recovery after revascularization, whether with stent or surgery. And just a couple examples here. This at top right is the first pass perfusion, a normal case, and then this is an abnormal case, and we'll show a couple of abnormal cases as well of an infarct pattern at LGE. So again, I'll go over this in more completeness with our cases, but you may have seen diagrams like this. This is just one particular example. A lot of different publications and websites have different variations of this. Again, I'm not going to go over this specifically right now, but this is maybe one thing to kind of, if you're listening live, to kind of just search online and have at your side if you're listening at a later date, just to kind of have while we go through the actual cardiac MR images. But this is just to illustrate that some patterns of LGE can suggest different diagnoses. And again, we'll see this right now. So that's just a little bit of introductory material. Again, I could spend multiple hours going over those in more depth, but I think it's just more illustrative to go over cases, and they will kind of reinforce the sequences and just see some cool pathologies. So again, I'll have a little bit of a clinical vignette, and then based on this vignette, kind of how I would approach the study and kind of what protocols, so to say, I would use, and then we'll kind of go into the key findings. So first, we have a 65-year-old male, known 3-vessel coronary disease, and we're considering this patient for potential revascularization. So generally, this is kind of translation for a viability study. So for each of these cases, I'll kind of go over a particular protocol. This will relatively be, or pretty much be repetitive, though I'll kind of go over some key additions or subtractions for each of these. Again, this is debatable. Cardiac MR protocols are pretty variable amongst institutions, so don't get too tied. If you've seen other things being done, by all means, it's not right or wrong, but this is how I would potentially approach each of these problems in a hopefully as efficient as possible manner. So for pretty much everything, I'll kind of stop saying this after this, but scout and large field of view images and Cine SSFPs are pretty much standard. For this, again, I have a little bit of a preference toward multi-parametric mapping, but I would argue that this is potentially optional if you're really just looking for viability. And for viability, delayed enhancement is arguably the most important part of information we get from this exam. What we really don't need here, assuming nothing else is going on, phase contrast, MRA, and stress. I know we're dealing with ischemia, but the diagnosis of ischemia and coronary disease is known in this situation, so I don't think stress would add a whole lot. So the first case here, I'll show basically for all these, I'll show usually 3, maybe 4 key images and sequences and kind of describe what's going on and kind of how these images constitute our diagnosis here. So short axis SSFP at the mid-level here, we see overall pretty normal function, except for this lateral wall here, which at baseline is a little bit thin. Also is not really moving or contracting or thickening quite as well as the anterior septal or inferior segments here. So we have a regional wall of motion abnormality here on the lateral side. Just another way to see it here on the 4-chamber SSFP. Everywhere else it's thickening pretty well, except it's just not thickening all that well here. Basal to mid wall here. Mid short axis LGE, we see subendocardial delayed enhancement here. So when we think subendocardial delayed enhancement, this is really pretty pathognomonic, especially when it's focal in a particular coronary distribution. This is pretty much diagnostic for sequelae of a prior infarct. And again, we're doing this for a viability study. So the answer or the question of viability is typically answered, is there LGE? And if there is LGE, to what thickness or extent is it occurring in the myocardium? So really it's a percentage of thickness. So in this portion here, I would say it's less than 50%, maybe closer even to 25%, but definitely less than 50% of the thickness of the myocardium in this segment. So since it's less than 50%, I would call this viable, or another way of saying it is a high probability of functional recovery after revascularization, however you're going to do it. A companion case here, I'll show up a couple companion cases. This patient has already had a prior sternotomy. We can see in terms of a regional wall motion abnormality, this inferior wall here, arguably I would say is akinetic, possibly even dyskinetic, in the sense that while everything is kind of contracting and moving in, this is kind of just bulging out. I think you actually see this a little bit better here in the 2-chamber. We can see all the other chambers are contracting relatively normally. Here, this is, again, not really thickening at all. If anything, kind of bowing out as everything is kind of moving back in. And the LGE short axis, about this slice, about mid to basal slice here, you can see relatively full thickness. There might be a little bit of spared, null, normal myocardium here, but for the most part, this is pretty full thickness late gadolinium enhancement. So since this is near full thickness, certainly greater than 50% of the thickness, I would consider this non-viable myocardium.
Anyway,
Or again, another way of saying this is probably a lower probability of functional recovery if you were to go in and revascularize that territory, that RCA territory. Another flavor of kind of ischemic heart disease here is the concept of an acute MI. I would argue that there's certainly much better ways and more efficient ways to diagnose an acute MI rather than cardiac MR, but sometimes we do see these patients for whatever reason. So it is good to recognize kind of what in a more acute or subacute MI looks like. Fortunately, this cine is not playing right now, but let's just imagine we have some wall motion abnormalities here in the mid to apical myocardium here. I talked about this concept of T2 maps. So this is a way to just quantify T2 signal, and elevated T2 signal meaning edema. So it's a little bit subtle here, but just as a reference here, the basal septum here is a little bit darker. These are lower T2 values. This lateral wall here is lower here, is kind of subtle, but we have some increased T2 values here at the mid, particularly the apical septum, the true apex, and a little bit of the apical lateral segment. So that's indicative. We have some myocardial edema. And then mid-short axis LGE here, we have pretty much transmural delayed enhancement here in the anterior and especially the septal wall here. So constellation of findings, we have transmural LGE in an LAD distribution, associated edema. So this has a good look for an acute LAD territory infarct. Kind of another flavor of acute or ischemic heart disease or infarct is this concept of microvascular obstruction. Some people call this MVO. So from a wall motion functional standpoint, again, we see some pretty hypokinetic segments here. Again, this in the LAD territory mid and especially apical LAD territory, certainly not moving quite as well as the other segments were. From an LGE standpoint, again, we see not in some areas transmural, but some areas at least 50% thickness. Subendocardial LGE here at the mid and apical myocardium. But what's different about this compared to the first two cases and the other cases we saw with LGE and ischemic heart disease are these little black dots or these little black things kind of in the center of this LGE. So this is the microvascular obstruction. Whenever you have essentially non-enhancing myocardium kind of bathed in the background of kind of infarct pattern LGE, this is basically MVO, or another way of some people say this is kind of no reflow phenomenon. So really this still indicates that the patients had a prior myocardial infarction, but this is essentially like really damaged myocardium. Just another way of looking at it here, short axis essentially through this level here. Similar findings here, you see the LGE, but kind of in the center and the interior of this LGE. It's not even enhancing kind of at this point in the exam. And then just to kind of finish this off, probably the most extreme case or kind of the most extreme consequence of a prior MI is the concept of aneurysm. So we have a 2-chamber cine SSFP here. It's actually relatively normal elsewhere myocardium with the exception of here. So we have this aneurysm that's essentially bulging out from the inferior basal aspect. Not surprisingly, this myocardium here is essentially not moving at all. The cine, unfortunately, is also not playing, but same concept, basically a short axis through this level. We see this thinned out, bulged out aneurysmal inferior segment here. And again, not surprisingly, when we do LGE here, there's thinned out segment here. It's kind of hard to appreciate just because the myocardium is so thinned out, but we basically have transmural LGE here, indicating that this is the sequelae of a prior MI. And of course, this is non-viable at this point. So those are just kind of a spectrum of kind of infarct imaging. After each of these cases, I'll go over just basically one slide of kind of summary statements here. Again, you could argue kind of ischemic or infarct imaging is a lecture unto itself. This seems kind of obvious, but just a very fundamental principle is that infarct and viability findings, they follow classic coronary distributions. From an SSFP standpoint or a functional standpoint, you can have normal thickness, especially if it's either less severe or in the acute to subacute setting. The myocardium hasn't had time to remodel yet. So generally you will have normal thickness. When it gets more severe or chronic, then you're going to get wall motion or structural changes or wall motion abnormalities that can get thin. In the most extreme case, you can get aneurysmal, and then anything on the spectrum from hypokinesis to akinesis or even dyskinetic segments. Mapping, if you're going to do it, again, I don't have strong feelings here that you do it, but in the setting of an acute or subacute MI, you're going to have findings of edema or elevated T2 values. And then, of course, if you have scarring, that's going to lead to fibrosis, in which you'll have some elevated T1 values or ECV. And again, I would argue the most important part of this exam is the LGE. At a minimum, you're going to have subendocardial LGE. If it is more severe, it's going to progress all the way to transmural or full thickness LGE. And when asked for whether this myocardium or a particular segment is viable, it's really dependent on the extent of LGE, and usually the magic number again is 50%. In more severe cases, in kind of worse prognosis, you may see MVO or microvascular obstruction. Again, that's kind of these central areas of non-enhancement, kind of surrounded by infarct pattern LGE. So kind of staying in the same vein, but just a slightly different flavor. Second case here, 68-year-old male, type 2 diabetes, hyperlipidemia, and a family history of coronary disease, just really presenting with dyspnea and exertion and basically evaluation for coronary disease. So at this point, there's not certain this patient's had a prior infarct. We're really just kind of evaluating for, does this patient have significant ischemic heart disease, yes or no? This would actually be a potentially good indication for CMR stress. So how do we do this protocol? Basically, it's basically what we just did, and then we're going to add, to actually evaluate the stress component or the ischemia component, we're going to add these first pass perfusion sequences done at stress and rest. There's a number of different ways you can do stress exams with MR. Here we typically do, it's pretty much required you have to do medication, since exercise is typically not conducive to an MR scan. Here at our institution, we usually do adenosine, or for patients who can't receive adenosine for contraindications, regadenosine, but something in that family. Some institutions do dobutamine. It's really site dependent on that. So here's a case here. I know this is a pretty busy with four cines or 3 cines going at once. I'll let this play for a couple seconds, but I'll show a couple key still images. But really the takeaway here in the functional, I'm just showing this mid SSFP here, really just to show that the patient has normal function at this level here. I'll stop here and just show the salient findings. So we have stress and rest images at this level here in the mid short axis. So on this particular stress image here, we see otherwise in the background of normally enhancing myocardium, we see this subendocardial perfusion defect in the anterior here, where the arrow is in the septal, and maybe even a little bit here in the inferior, at least inferior septal segment. Compared to rest, after the adenosine has kind of washed out and has been turned off, at rest, it's basically normal. And then really just showing here this mid short axis LGE, just to show that there's been no evidence, there's no LGE, there's been no evidence of a prior infarct. So constellation of findings here is inducible ischemia in the LAD distribution. A companion case a little bit more severe. So mid short axis SSFP here, pretty much a normal function with the exception here at the inferior wall. It's not quite akinetic, but it's not, I wouldn't say it's moving quite as well as the rest of the segments. You can maybe make the argument it's also kind of in the background, a little bit thinned here. Stress and rest images, just like last time. I'll stop it here to show kind of the salient findings. So we do have actually, as opposed to the other one, we do have abnormalities both at rest and stress. It's a little bit subtle, at least on my screen here. But we do have some subtle, even at rest, subendocardial perfusion abnormalities kind of underneath my cursor here that becomes a little bit more pronounced during the stress portion of the exam here in the infroseptum, inferior and infralateral segments, as opposed to relatively normal here more anteriorly. Yet this patient also has normal LGE, no evidence of a prior infarct. So when we have an abnormality at both rest and stress, albeit worse at stress, this is a good example for rest ischemia. And generally, you have a rest ischemia, that means you have a pretty bad, almost, this was labeled as 99% stenosis here in the RCA territory. So in terms of ischemic value, again, I said this before, but when you're dealing with anything ischemia, ischemic findings really follow the coronary territory. So just always keep that in mind. From an SSFP standpoint, we saw a couple different cases here. It could very well be normal, and honestly, often without a prior infarct, these tend to be normal. But if it is severe and it is longstanding, that you can develop hypokinesis in the affected territories. So when you're doing stress exams, there's basically 4 different options that you could be calling here. So the normal, I didn't show normal, but basically normal is you have normal perfusion at stress and rest and no prior infarct, no LGE. The first case I showed was reversible ischemia in the sense that you have an abnormal stress, you have subendocardial hypoenhancement during the stress portion of the exam, which is normal or resolves at rest, and you have no infarct. When you have rest ischemia, or the second case I showed, pretty uncommon, but we can see it, is you have abnormalities in stress and rest portions, albeit the rest is the stress is more pronounced than the rest findings, yet you have no infarct. One other option that you have that I didn't show here is the concept of peri-infarct ischemia. So that'll be, you'll have both abnormal stress and rest, and the rest perfusion abnormality will correspond to an LGE scar. So you've had a prior infarct, but basically the surrounding segments are ischemic, and that what constitutes peri-infarct ischemia. Moving on a little bit, so when that's basically a summary kind of a ischemic heart disease, we'll move away to kind of more non-ischemic cardiomyopathies for pretty much the rest of the talk. Another case, 20-year-old male presenting with chest pain, elevated troponins after a recent viral illness. So by history, this has a good look or a good concern for myocarditis. Some places have a actual myocarditis protocol. Just to broaden this a little bit, I would just kind of approach this as a cardiomyopathy NOS, but evaluating for acute inflammation in association with a cardiomyopathy. So very similar protocols. Really the only thing I would add here, and I would consider mandatory for this one, is either multiparametric mapping, either especially something T2 mapping, or if you don't have a capability or comfortability with multiparametric mapping, what traditionally is done is more qualitative imaging. In this case, I would do some sort of stir imaging or T2 with FAT-SAT, dark blood imaging to really something to detect edema. And I have mentioned here, I'm not going to show these images here. This is maybe a little bit more historical, but especially if you're evaluating for myocarditis, some would argue to potentially do some early post-contrast imaging. And that's really to evaluate for findings of hyperemia or capillary leak that you can see with myocarditis or some acute myocardial inflammation. So a couple examples here of myocarditis, acute or subacute myocarditis. So from a functional standpoint, SSFP at the base, you can see at the inferior aspect and the lateral aspect, relatively normal wall motion abnormality, as opposed to the septum, especially anteroseptum and anterior. This is a little bit sluggish. It's contracting and thickening a little bit, but not quite as robustly as the rest of the myocardium. Just showing the basal, the corresponding T2 map here. This one actually has a color scale to guide you, but inferior and lateral aspect, this is relatively normal. Non-edematous myocardium may be safe for a little bit here, but the anterior, anteroseptal, anterior aspect, this is what we're looking for in our T2 maps to show elevated T2 values in myocardial edema. And to really kind of make this complete LGE at this level, we see LGE in the corresponding territory. So anteroseptal, anterior, even anterolateral, and basically also your entire lateral segments, we see LGE. But as opposed to the ischemic heart disease and the infarct I just showed you, this is in a non-ischemic distribution. So this is predominantly in the mid-myocardium here, and then arguably here it's mid-myocardium becoming subepicardial here. So basically the subendocardium is spared. So we know that this is not a prior infarct, and this is something non-ischemic. Kind of a companion case just to show it in a slightly different light. kind of how T2 maps correlate with more traditional dark blood images or stirs here. So these are two 3-chamber images here. So this is a stir. It's a little bit subtle here, which is why I like T2 maps sometimes, because on dark blood images, it can be a little bit subtle and a little bit subjective, but the arrows here showing some patchy increased signal or patchy increased edema here in the basal infralateral, mid infralateral, and towards the apex. This here sometimes gets confusing here. This is actually still within the cavity of the left ventricle. This is actually a little bit of slow flow artifact. This is not actually myocardial edema. And then just, albeit not specific, but supportive, we do have a little bit of pericardial fusion here. What this looks like, same patient, same plane, T2 maps. I would argue you can maybe see it a little bit more conspicuously here, and you can also quantify, but this is the corresponding finding here in the T2 map. And then the LGE pattern is also here typical for myocarditis. We see mid-myocardial and subepicardial LGE here in the especially inferior and infralateral segments here. So in terms of myocarditis, you may have heard of Lake Louise criteria, which has been relatively recently updated. I kind of prefer the updated Lake Louise criteria. It's a little bit simpler, and I think it kind of incorporates some of the more contemporary sequences that we're typically using. But basically what we're looking for here, two main criteria. Evidence of myocardial edema, whether regional, and it typically is regional, but it can be global. And however you want to assess that, either on dark blood stir images or T2 maps. And then evidence of non-ischemic myocardial injury. That is typically done using LGE, but if you can't give contrast, you can potentially do T1 maps as well. Supportive criteria, not mandatory, but can certainly support your diagnosis of myocarditis. Contemporaneous signs of pericarditis, which we would see as pericardial thickening and enhancement, and plus or minus diffusion, which you can see on a number of different sequences, but typically your SSFP, excuse the typo here, as well as LGE. And then regional wall motion abnormalities are typically accompanying the affected segments, whether regional or global. And of course, that's assessed in your SSFP images here. I have down here as a question mark. This is a little bit institution cardiology dependent. Usually, myocarditis is typically regarded as self-limiting, but some may subscribe to the fact that, or the option that you might want to follow these up with cardiac MR to ensure resolution of edema, potentially assess for kind of residual scar. I would say that's optional, but the protocol and the assessment is still the same. Next, 49-year-old male presenting with first-degree AV block on a preoperative EKG, and he has known chronic lung disease. This is a good kind of scenario. Usually these patients have known sarcoidosis, but this is a good scenario for the possibility of sarcoidosis. And I would do the same exact protocol as our last one here. Again, a kind of a combination of a viability cardiomyopathy protocol. Sarcoidosis can have an acute component, so I would make the argument doing something to assess for edema. So what does sarcoidosis look like? I think this is a pretty good example here. So mid short axis SSFP, actually this is pretty normal, and it very well can be. LGE, however, is abnormal. So I'm showing this at a couple different planes here. So the mid short axis LGE, we see a couple kind of patchy areas of involvement. So here in the mid infralateral segment, we see pretty much mid myocardial here. We see a sliver of spared subendocardium. We see some spared normal subepicardial here. We see kind of similar finding here at the RV insertion at the infralateral segment. We also see a little bit of RV involvement here, kind of at the RV free wall. So certainly in a non-ischemic but multifocal distribution. Two-chamber LG just showing it in a different light, just highlighting the inferior involvement here. We see kind of a dotted mid-myocardial involvement here, here, and then here even towards the apex. And then this patient had a chest CT here, which shows not showing the lung involvement, but certainly showing the mediastinal and nodal involvement here of lower mediastinal hilar adenopathy. If you don't have a chest CT, this is, again, also the value for the large field of view images. Usually if adenopathy is large enough, you can actually see it on large field of view images and kind of make the diagnosis, or at least support your diagnosis there. Just another example, kind of showing a more of an acute edematous active inflammation involvement or sarcoidosis. So this patient here actually has in the wall motion abnormality here in the mid-infroseptal segment. This particular segment here is barely moving and thickening. I think a little bit more subtle here. I'm not sure how it's projecting, but they do on this T2 map here have a little bit of edema in this infralateral segment compared to the other segments. And then LGE here is surely supportive of sarcoidosis. We see mid-myocardial delayed enhancement in the mid infraseptal segment here, becoming a little bit more subepicardial here at the RV insertion. And then again, using all of your information on the scan, this patient also has an enhancing splenic nodule. Of course, splenic lesions have a wide differential diagnosis, but in the setting of known sarcoidosis, this would definitely be supportive of splenic sarcoidosis. So sarcoidosis is one of those things, not only in the heart, but in the lungs, the brain, can have a wide variety of imaging appearances. So I'll kind of go over classic appearances, which would be, again, in a non-ischemic pattern, so mid-myocardial and or subepicardial distribution. Some might say when it involves the septum, if it's kind of subepicardial on the RV aspect of the septum, that's a little bit more specific for sarcoidosis, as opposed to maybe something else like myocarditis. And then you can certainly have biventricular involvement, so left and right ventricle involvement are certainly fair play. However, I've probably seen sarcoidosis look pretty much almost like anything. I've seen it look transmural. I've seen it, mimic for the life of me. I've probably been wrong and called it a prior infarct, and I've seen it even being mass-like. So I've certainly been humbled by what sarcoidosis can look like. Additional findings, again, look for wall motion abnormalities on your SSFP images, what may or may not be present. Sarcoidosis can be chronic or can have an acute inflammatory component, so certainly look in your T2 maps or STIR, however you assess it. And this is one that can certainly have non-cardiac manifestations, which we can still see in our exam, so mediastinal hyalurionopathy. MR is certainly not the way you would go about looking for pulmonary fibrosis or pulmonary changes, but it certainly can be seen. And then we typically catch the spleen and the liver on our exams, so certainly look for that involvement there. Next case, 57-year-old, history of multiple myeloma, presenting with volume overload, dyspnea on exertion. So really the history of multiple myeloma and some sort of cardiomyopathy, that's a good history for amyloidosis. So this would just kind of fall under a general cardiomyopathy assessment. And then what I would just say is our general cardiomyopathy assessment here. So a couple examples here from an SSFP standpoint. 4-chamber here, we can see just overall from a biventricular standpoint, not the worst function I've ever seen, but it is, I would say, both left and right ventricle are globally a little bit down. The notable finding here from a morphologic standpoint is, I would say, some mild to moderate, sorry, the Cine stopped playing here, but mild to moderate, both left and right ventricular hypertrophy, and does have some atrial enlargement, particularly the left atrium here, and kind of subtle, but I would argue it has some atrial kind of wall and septal thickening as well. Again, I'm sorry this stopped playing by itself, but this is one pathology, probably the only pathology that I can think of, where the TI scout images, which are typically done to kind of optimally set parameters for your LGE images, have diagnostic information. So normally when you do your TI scout images to kind of essentially select the TI value that'll optimally null your myocardium for your LGE images, as you progressively increase the TI values, the usual kind of pattern of enhancement and nulling is that the blood pool nulls before the myocardium. In amyloidosis, just given the deposition and the amyloid circulating within the blood pool, the opposite is true, which I'll play here right now, and I'll slow it down. So as I'm going here and progressively increasing the TI times, we can already see here that the myocardium has become nulled. And then a couple time points later, then the blood pool becomes null. So this is the flip-flop of what's normal. And this is actually pretty diagnostic unto itself for amyloidosis involvement. From an LGE standpoint, this is one where you have, at least classically, have diffuse subendocardial involvement, both left and right ventricle. And even if it gets bad enough, the atrial septal walls can enhance as well. So that's seen here. Another example, so amyloidosis can come in a couple different flavors. I'll say most commonly we see here is light chain amyloidosis, typically in association with multiple myeloma. You can have ATTR transthyretin associated amyloidosis. Really, from a cardiac MR standpoint, the imaging findings and structural findings are similar. So this is an example here. We have biventricular hypertrophy, a little bit of atrial wall thickening, particularly here at the septum. LGE is same, pretty diffusely subendocardial delayed enhancement. Here it's a little bit more patchy, which you can certainly can be with amyloidosis as well, LGE of the atrial walls as well. Something that we do here that's been shown to have be pretty specific for at least ATTR amyloidosis is a nuclear medicine study, the PYP scan, technetium-99m. That is pretty good at confirming it has high specificity for transthyretin amyloidosis. So again, amyloidosis has a number of classic findings, starting with morphology. Again, mild to moderate concentric ventricular hypertrophy. I don't know if it was really pronounced here, but on the cases I show, but classically a biatrial dilation. EF it can be normal, but typically is mildly decreased. And you can also have not only with atrial dilation, but atrial wall thickening and septal thickening. I mentioned the TI scout. So normally these are kind of an afterthought and may or may not even be seen, and they're more from a technologist standpoint, for technologist uses. But this is one where you can get actually a lot of diagnostic information, seeing that kind of abnormal nulling, pharmacokinetics. Again, mapping, I didn't show mapping here, but this is one where I think T1 mapping and ECV are of value. These typically have pretty markedly elevated T1 values in ECV. LGE pattern can be a little bit variable, but what's classically described is diffuse subendocardial enhancement. And I show, especially with that second case, sometimes it gets kind of very kind of wonky in the sense that on all of our other LGE images, the blood pool remains bright, but sometimes in amyloidosis imaging or LGE images, the blood pool is actually dark relative to the enhancing myocardium. But sometimes you have atypical cases. Sometimes it just looks kind of diffuse, patchy enhancement. Next case, 25-year-old, recurrent ventricular tachycardia. It turns out she has a strong family history of cardiac arrhythmias, even sudden cardiac death. So this kind of history and demographic typically leads to an ARVD evaluation or ARVD evaluation. So this protocol here is kind of like a cardiomyopathy. The only thing I would particularly add here, so traditionally, in terms of SSFPs, I would say kind of at a minimum or a standard is you get a short axis stack down the ventricles, plus or minus a little bit of the atria. This is when I would do a little bit more imaging here. In addition to the short axis SSFPs, I would also get kind of a stack of 4-chamber images and then also potentially some selected images highlighting different aspects of the RV, such as the RVOT. And that's really to pay attention to the RV and look for some subtle wall motion abnormalities. I also have starred here, and I'll show an example of this. Some people for ARVD assessment will do fat selective imaging to look for fatty infiltration, fatty fibrosis in the right ventricular wall. I'll make the case that that's not necessary, but you can see it in advanced stages, and at least here, sometimes it still shows up on board exams as kind of a classic finding. So what does ARVD look like from a structural functional scenario? So I have two just at slightly different slices here, 4-chamber Cine SSFPs. This RV is abnormal in the sense that the function just overall is not contracting all that well. It's a little bit dilated, and I think really the key thing to look at here is that really there's no kind of concerted contraction. Some people call this the accordion sign. So normally the RV contracts kind of both in a radial and kind of longitudinal fashion. This just seems to kind of be like, as an accordion does, kind of just like crinkling, and kind of all the different segments are kind of just marching to the beat of their own drum, so to say. So that would constitute regional moral motion abnormalities of the right ventricle. I'll kind of spare the details here, but this is what the functional parameters turned out to be. We have a low EF, we have dilated RV by index volume. So this meets major task force criteria for ARVD, and I'll go over what that all means in a second. Kind of a companion case, this is a little bit more of a severe case. We typically don't see our ARVD progress this severely much anymore, since it's this gets tested and screened for much sooner than it used to be. But this is an advanced, arguably end stage case. So I mentioned before the concept of fat selective imaging. So I didn't go over this in the beginning, but we can do, like as you potentially would in abdominal imaging, you can do in and opposed phase to select for fat. So really the finding here is on the opposed phase imaging here, the RV free wall has pretty diffuse India ink artifacts, suggesting diffuse macroscopic fat infiltration. And then LGE is not necessarily a criteria for ARVD, but in severe cases you can have LGE, and this is actually pretty severe and pretty extensive in the sense that your RV, pretty much the entirety of your RV, even creeping into the septum here, has diffuse LGE. So I mentioned this task force criteria. So whenever the question is ARVD, basically you need to do something to fulfill or assess for these task force criteria. Personally, I don't have these memorized. It's a lot of just a lot of numbers to memorize. But there are major and minor criteria, and the quantitative criteria are somewhat different, males versus females. But the things to highlight here, at a minimum, you need to have evidence of right ventricular akinesia, dyskinesia, or dyssynchrony. And then one of these following criteria, either volume criteria or EF criteria. And again, the major criteria a little bit more restrictive compared to the minor criteria. One thing of note when you're reporting, so the concept of ARVD, imaging only plays a subset or kind of a small set of the diagnosis, which includes clinical criteria, electrocardiographic criteria, family history criteria. So when we're reporting it, basically you report parameters and findings that meet imaging criteria, task force criteria for ARVD. The diagnosis of ARVD is a much bigger thing that needs kind of clinical correlation, clinical assessment. And I mentioned some things that can be seen either kind of in advanced or late stages or board exams. Is the concept of RV LGE or RV fatty metaplasia, but you do not need to see these. These do not need to be present to diagnose ARVD. Next, 13-year-old female, I should say she had a screening echocardiogram for some reason, and it noted increased trabeculations. So this is a good scenario for the concept or the pathology of LV non-compaction. So this would just be a kind of classic cardiomyopathy protocol. So what does non-compaction look like? Really, this is a morphologic assessment. So all you really need is good SSFP images. So as opposed to all the other kind of appearances of LV we've seen here, very trabeculated here. Normally a little bit of trabeculations and a little bit in the LV is okay, but this is too much. How do we quantify and formalize the assessment of LV non-compaction? Basically, it's this concept of non-compacted to compacted ratio. So I froze frame here, but typically assessed on the short axis images, has to be on the end diastolic images. Basically, you just measure the non-compacted or the trabeculated myocardium and compare that to your normally compacted or normal myocardium. And if that ratio is 2.8 or above, that meets morphologic criteria for LV non-compaction. You can also have, this is a little bit more, I think, personally harder to diagnose. You can have RV non-compaction. This one's a little bit harder in the sense that the RV typically is more trabeculated, but you can have RV involvement as well. LGE, in this case, typically is normal. I just really showed here this patient has a completely normal LGE image, so that does not have to go into the diagnosis of LV non-compaction. So what is LV non-compaction? Basically, I'm oversimplifying the embryology here, but it's basically an arrest of compaction during intrauterine life. So this kind of falls under the congenital heart disease spectrum. This can present as heart failure. And if patients do have pretty profound heart failure, they can have systemic thromboemboli or can present with arrhythmias. And again, really that diagnostic is this morphologic criteria of non-compacted to compacted ratio. Again, emphasizing this should be measured in end diastole. LGE can be completely normal, but if you do have LGE, typically the most commonly described pattern is mid-myocardial, but again, could very well be normal. Next case, 44-year-old male, history of beta thalassemia, multiple transfusions, new onset heart failure. So for patients who are transfusion dependent for whatever reason, typically beta thalassemia, here in the States, we see a lot of sickle cell disease, for whatever reason, iron overload cardiomyopathy is a particular concern in these patients. So iron overload protocol, so to say, is a little bit unique in the sense that really the most, certainly we get SSFP images to evaluate for function, but probably the most important thing, if you're going to do only one thing on your exam, is this T2 star mapping, and that's how we quantify and assess actual iron overload. Sometimes here at our institution, these exams are, if that's really all they want to know, sometimes these scans are ordered without contrast because T2 star assessment does not require conscious, but if they do want kind of a comprehensive cardiac MR to look for scar for other reasons, certainly we can't do things with these exams with contrast, but that's why I listed optional here. So what does iron overload cardiomyopathy look like? So in terms of function, it could very well be normal. This is a case that's a little bit more advanced, so it actually does have decreased systolic function, but just kind of in a mild global fashion. So the T2 star mapping, I'm not going to go kind of into the physics. It's a little bit complicated how these maps are constructed, but just from a general standpoint, you basically take repeated images in whatever plane you want, but typically it's done in a mid-short axis level. And really what is going on here as this thing is playing is you're progressively, all these time points in these image series here are progressively longer TE times. So normally the signal, the myocardium, as you prolong your TE times, really shouldn't change all that much, as opposed to this case here where the signal intensity in the myocardium is pretty dramatically decreasing as you increase your TE time. So that suggested that there's some sort of susceptibility, namely iron, deposed in your myocardium. Also a commonly seen thing in these patients here, because iron can go into a number of different organs. So typically in the field of view here, we have the liver. So a common ancillary finding here is iron overload in the liver as well. I mentioned we can quantify, so on these maps, you can actually quantify, you draw your ROI, typically in the mid-septum here. We've got a value of 6 milliseconds, which is markedly abnormal and consistent with severe iron overload. So iron overload is kind of what you think it is, accumulation of iron in the myocardium leading to diastolic, and then kind of in end stages could have a systolic component. Again, this is pretty much quantified with T2 star maps. Normal is T2 star above 20 milliseconds. What's considered mild to moderate, some of these ranges are a little bit debatable, but mild to moderate iron overload tends to be a T2 star between 10 and 20, but particularly less than 10, you're in the severe range. I didn't show any T2 or T1 maps, but if you are doing T1 maps, this is one of the few pathologies that will actually decrease your T1 times. And again, just to kind of be full service, check for other organ involvement, which typically will manifest earlier than cardiac involvement, but liver, spleen, marrow, among other organs. So just be aware of that. 75-year-old heart failure, reduced ejection fraction. This patient has had a prior angiogram, which curiously showed non-obstructive CAD. So this is just a cardiomyopathy assessment, our pretty much standard protocol that we've been doing thus far. So we can see from a functional standpoint, globally enlarged heart, arguably all 4 chambers are enlarged. Severe global hypokinesis. It's maybe a little bit more profound here in the septum. I would argue this is not moving at all compared to maybe severely hypokinetic, but for all intents and purposes, pretty much a globally reduced ejection fraction. And then the LGE here has a somewhat unique pattern in the sense that really just involving the septum, we have this linear mid-myocardial delayed enhancement pattern here. So this is pretty pathognomonic or suggestive for idiopathic or dilated cardiomyopathy. Certainly not in an ischemic distribution given its mid-myocardial involvement. Just a companion case showing the same findings, just in a slightly different light. Excuse the typo here. This is a short axis Cine SSFP through the mid-level. Again, global hypokinesis. This is just a plug for native T1 mapping. If for whatever reason the patient couldn't get contrast or did not want to get contrast, you can see an analogous finding here where you can see in a somewhat linear mid-myocardial distribution elevated native T1 times on this color-coded map. And again, same findings here on the LGE, thin, linear, mid-myocardial delayed enhancement within the septum. So idiopathic dilated cardiomyopathy, it's kind of what it sounds like again, non-ischemic dilated cardiomyopathy, not attributable to a known entity. So it's kind of like a diagnosis of exclusion. Typically what we see, as the name suggests, dilated LV, and usually these patients have a pretty profoundly reduced systolic function in more of a global fashion. Classically described LGE pattern is what I showed here, linear mid-myocardial involvement of this pretty much the septum. Really the purpose of these exams is oftentimes not necessarily to diagnose idiopathic dilated cardiomyopathy, but really to exclude subendocardial or exclude the evidence of a prior infarct, which have a markedly different kind of treatment pattern. And then again, for patients who do have a pretty profoundly reduced ejection fraction, I mean, anytime you have a profoundly reduced ejection fraction, either low regionally or globally, you can have thrombus. But these patients, at least anecdotal in my experience, these patients certainly have thrombus when this involvement is severe. Next case, 75-year-old male syncope, follow-up echo with evidence of basal septal hypertrophy. So this is a good look, both history-wise and echo-wise, for HCM or hypertrophic cardiomyopathy evaluation. So this is a little bit of a unique protocol. Most of the stuff is the same, but this is one from a cardiomyopathy standpoint where I would add some phase contrast images here, because if you're going to be assessing and kind of staging, so to say, hypertrophic cardiomyopathy, really a good prognostic and treatment evaluation incorporates LVOT velocities and pressure gradients, and then these patients may or may not have mitral regurgitation, which may be useful to quantify. So a couple cases here of kind of more classic hypertrophic cardiomyopathy, which typically affects the basal to mid septum. So I really like 3-chamber SSFP images to evaluate both the morphology and kind of sequelae and complications of hypertrophic cardiomyopathy. So we see basal, even kind of creeping into the mid here, pretty asymmetrically hypertrophied myocardium compared to the apex and the lateral segments. So one thing that typically gets attributed as a consequence of hypertrophic cardiomyopathy is this concept of SAM here. Is basically you have this increased flow acceleration across the LVOT here, and it's kind of hard. Unfortunately, I can't pause it to kind of give you a slow motion view of it, but during systole, basically what SAM is the anterior leaflet of the mitral valve gets kind of paradoxically sucked in, leading to this LVOT gradient here. Just another view from a morphologic standpoint in the short axis, you can just better see, I think, the asymmetric hypertrophy here, the anterior septum, inferior septal segments compared to a very normal looking lateral segment. And this is a pretty classic LGE distribution. So hypertrophic cardiomyopathy may not have LGE, but if it does, this is pretty classic. Some kind of patchy mid-myocardial delayed enhancement, usually within the hypertrophied segments, usually at the RV insertion points here, anteriorly, and then to a lesser extent, kind of posterior inferiorly here. And then just to kind of slow it down here, this is, again, kind of this kind of paradoxical anterior systolic anterior motion of the mitral valve, and this is how you assess it morphologically. At end diastole, you measure the thickness of the greatest hypertrophied segment compared to usually the lateral segment at the same level. Just another example, again, kind of incorporating the phase contrast imaging here. So from a 3-chamber SSFP image, pretty much the same morphologic findings we saw earlier, but the concept of phase contrast imaging, again, this is where you quantify velocities through the LVOT and then therefore calculating pressure gradients. So phase contrast imaging, without going into too much detail, typically in a single acquisition, you get a magnitude image and a phase image here. Unfortunately, this Cine is not playing, but from a post-processing standpoint, typically you kind of get down the barrel or orthogonal to your area of highest velocity, and you can draw an ROI and quantify. In this particular case, the LVOT resting velocities were pretty markedly elevated at 4 meters per second, which with a modified Bernoulli equation translates to a pressure gradient of 65 millimeters of mercury. A couple other cases, or a couple companion cases. So classically, hypertrophic cardiomyopathy is septal involvement, but you can probably the next, actually, excuse me, this has to be the next case. So this is another case here of pretty profound. Again, this is arguably even thicker involvement of the septum here. What can be done in these cases is you can do stress tests with these patients, and they have a little bit of a different abnormality compared to our ischemic patients. So they still have abnormalities kind of subendocardially, but these patients can have evidence of almost microvascular disease. So they still have subendocardial perfusion defects, but it's really kind of global. It's really more pronounced in the hypertrophied septal segments and a little bit more ill-defined compared to the patients with ischemic heart disease. So this is kind of a finding if you were to do a stress test on these patients, what may be found. And this is another example here of LGE. This one's a little bit more severe, a little bit more profound compared to the other ones I just showed, but still you have a little bit more focal involvement here. Pretty much throughout the hypertrophied segments, but more pronounced here at the anterior insertion, posterior insertion. And then sometimes when it gets really severe, they can have LGE involvement of the or at least not as hypertrophied segments. So I was a little bit premature in the last case. This is the case of the apical variant hypertrophic cardiomyopathy, in the sense that the kind of the basal mid segments are relatively normal, but we have asymmetric fusiform hypertrophy here at the apical segments. This is a kind of taking it one step further. Some patients with apical variant hypertrophic cardiomyopathy can develop apical aneurysms, and those apical aneurysms can go on to develop thrombi, which is not present here, but they do have apical hokum and an apical aneurysm. LGE, you can get LGE. Kind of intuitively, you can have a non-ischemic distribution in the hypertrophy segments, and if they do have apical aneurysms, you can get LGE in those aneurysms. So lastly, we rarely see this. Now I think hypertrophic cardiomyopathy is being increasingly recognized and increasingly kind of managed and treated, but you can have quote unquote end stage or burned out hypertrophic cardiomyopathy, which looks like this. So this one's very abnormal, but I think one in the basal to mid, you can kind of get the sense that there was underlying evidence of hypertrophic cardiomyopathy. But as opposed to our other cases, which had normal, if anything, hyperdynamic function, this patient has very abnormal systolic function. So this is kind of what we mean by the burned out aspect of it. The LGE here is a little bit, admittedly, this is probably the only case I've seen, but from the hypertrophy segment, septal segments, we do see evidence of a kind of non-ischemic pattern here. This one's a little kind of gumming up the works. This patient probably had a secondary insult. We do have subendocardial LGE here in the anterior and lateral aspects. So my suspicion is probably patient had a superimposed MI, but this is just an example of burned out HCM. And this is usually a very bad prognosis. These patients, if not treating heart failure, this is a potential indication for transplant. So hypertrophic cardiomyopathy, just to summarize, a lot of different phenotypes exist. This is just a spectrum here from a nice radiographics article. A here is normal. B and C are kind of what we typically see. And what I showed here, asymmetric involvement of either the basal septum or kind of fusiformly with the septum. We do see every now and then apical involvement where it's involvement to the apex, but things that can be seen that have been described, you can get diffuse concentric involvement. Admittedly, by imaging alone, this is difficult to just differentiate from just hypertrophy kind of NOS, but so perhaps I've probably seen this, but just have been unaware of it. You can get kind of mass-like involvement, multifocal involvement. These are less commonly seen, and honestly can be probably confused with neoplasia and masses. Just a summary of findings. So from a morphologic standpoint, again, assuming kind of the classic involvement, basal to mid septal hypertrophy, if you are going to get quantitative and measure, the ratio of the septum to the normal lateral segments is only 1.3. So if you really tried hard enough, you can give a lot of patients HCM. EF or function could be normal and even be hyperdynamic. It's actually a very bad sign when it's decreased. Look for signs of LVOT obstruction, which may be due to systolic anterior motion of the mitral valve, either the valve itself or the chordal apparatus, and you can kind of further quantify or analyze that via phase contrast imaging. You can, with all of this, have mitral regurg. I wouldn't say mandatory by any means, but some of our providers like to do stress tests on these patients, and you may see microvascular disease in the hypertrophy segments. And of course, evaluating for LGE, which typically is in a non-ischemic distribution, typically at the RV insertions. I know the guidelines on HCM therapies are kind of evolving, especially here in the States. But I can foresee in the near future LGE potentially playing a larger and larger role for AICD selection in these patients. So certainly LGE is something to comment on. Next pathology, 56-year-old male, progressive dyspnea, worse with supine positioning, TTE or echo with pericardial effusion and thickening. This is a good story for pericarditis, particularly constrictive pericarditis. This has pretty much a standard protocol. The only special addition here is with your cine images, as opposed to kind of your static breath hold images that we get pretty much everywhere else. The addition here is cine imaging, but in the setting of free breathing, particularly with deep inspiratory maneuvers, and that's really to elicit kind of findings of constrictive physiology. So a couple examples here. So you can see from an SSFP standpoint, unfortunately, cine just stopped playing here. I think the highlight here is the function is relatively normal, but the pericardium is very abnormal here. So the pericardium itself is actually pretty thickened, especially here anteriorly. Patient does have a small to moderate sized pericardial effusion. You can actually see the complexity of the pericardial effusion in the sense that there's some kind of linear, fibrotic, or whatever chronic inflammatory bands here. So I mentioned the concept of free breathing SSFP here. This is kind of what this looks like in the middle box here. So still SSFP, the image quality is not quite as good as our breath hold SSFPs, but I think we can still see some good information. Really what these patients do during real time, they're kind of tidally breathing, quietly breathing, and then soon coming up here, we'll eventually add, the technologist will ask them to take a deep breath in, which just happened right here, as evidenced by the diaphragm going down. And I'll show that here right now, just kind of as a replay here. So kind of in the normal case, the septum is kind of in its normal position, slightly bowed towards the right ventricle. When the patients take a deep breath in, as evidenced by the diaphragm going down, you'll see this diastolic septal flattening, and that's really what we're looking for as evidence of constrictive physiology. So this would be compatible with constrictive pericarditis in the setting of constrictive physiology, in the setting of an abnormal pericardium. Just another look at it, just for a couple of different aspects, a different case, but again, diffusely. This one really doesn't have a pericardial fluid component. It's really more of a diffusely thickened pericardial involvement. Again, this free breathing SSFP, you can see as the diaphragm is moving down, the septum is subtly becoming flattened as the diaphragm has moved down when the patient takes a deep breath in. Just from a post-contrast standpoint, this is just a kind of a straight up axial large field of view image. You can just kind of better appreciate the complex pericardial, a little bit of a diffusion, and just the thickening and enhancement that's making this patient have their constrictive physiology. One kind of unique feature of this here, sometimes we just see these patients kind of on a more with routine CT or routine imaging in a kind of a static view, especially when you have pericardial thickening plus or minus an effusion. These patients tend to have kind of more like a, especially when you get down to the apex, they have kind of more of a kind of cone-shaped heart here. These annotations are a little bit exaggerated, but kind of as opposed to all the other patients we've seen today, when you get down to the apices, due to the constriction, it tends to get very narrow there at the apices. And kind of another ancillary feature here is you can have atrial dilation, particularly the right atrium, as seen here. So constrictive pericarditis, this is often kind of a confusing clinical diagnosis because they tend to have a restrictive physiology. So usually this will get talked about with restrictive cardiomyopathies, although by imaging, very different appearance. So we do add a lot of value at MR. So you usually have an abnormal pericardium with thickening, especially if you have calcifications, that really makes your pericardium rigid, plus or minus an effusion. If you give contrast, the pericardium really does avidly enhance, and really the role of MR here is to really get a good look at the physiology and this idea of ventricular interdependence, and really what you're looking for is septal flattening with that deep inspiratory maneuver. And then sometimes we see some ancillary findings, just given the constrictive physiology. The IVC and hepatic veins tend to be very plump, very dilated, and you can have a contrast reflux. A couple more cases here. I know we're kind of getting to the hour time limit, but a couple more quick cases here. 54-year-old male, new onset heart failure with a notable history of peripheral eosinophilia. This is just a general cardiomyopathy approach. I always think these cases are pretty interesting when we see them. So from an SSFP standpoint, you can see as you saw, biventricular systolic dysfunction, and then this kind of notable filling defect here within the right lung apex. When we do a conventional LGE image, you can see rather diffuse subendocardial enhancement here, both the LV and the RV. And then you can see this non-enhancing filling defect here in the RV apex. We can do maneuvers with LGE imaging, basically empirically prolonging your inversion time. And what that does is make this filling defect have very low signal intensity, which confirms thrombus. So in this history, subendocardial, diffuse subendocardial delayed enhancement, apical thrombi, at least in the RV, this is a classic look for Leffler's endocarditis, or kind of on the spectrum of diffuse endomyocardial fibrosis. So clearly this is a restrictive cardiomyopathy in the setting of eosinophilic infiltration. And the kind of huge or kind of fun thing with these, or interesting thing with these, is that these are prone particularly prone, for at least reasons unclear to me, to apical thrombi, both within the RV and the LV. And then from an LGE standpoint, these will have relatively diffuse subendocardial delayed enhancement, at least in the ventricles. Last set of cases here, 45-year-old female, end-stage lung disease due to scleroderma. So basically, sometimes we do these cases to rule out or evaluate both for scleroderma involvement of the heart, as well as just kind of sequelae of pulmonary disease in the heart. So the way I approach this is basically a cardiomyopathy protocol. So these come in a couple different flavors. So sometimes you can actually see direct scleroderma involvement of the heart. So the SSFP image in this case was actually pretty normal, but the abnormality here is in your LGE. Admittedly, this is a kind of a non-specific, albeit non-ischemic LGE pattern, but really here in the mid-short axis LGE in the septum, you see mid-myocardial enhancement. You can see a dot of delayed enhancement here, kind of subepicardial infroseptum here at the insertion point, and then just in the tube chamber here, some additional areas of non-ischemic pattern LGE here throughout the inferior wall. So this has been described as a particular pattern of scleroderma involvement in the heart. Actually, probably what we more see, at least in our institution here, at Duke, we do a lot of interstitial lung disease, lung transplant evaluation. So we see a lot of patients with heart failure, particularly right heart failure due to primary lung disease. So probably in terms of scleroderma or just lung disease in general, this is probably a pattern or an appearance we see more. So this is a little bit more striking in terms of morphology, but this is a good example of kind of right heart strain, right heart overload, again, typically due to chronic lung disease. So just from a morphologic standpoint, you can see that the right ventricle and right atrium are quite dilated, particularly compared to the left. You can see a little bit of mitral regurgitation here with this dephasing jet emanating from the tricuspid valve into the atrium. And then this arrow here, so this right ventricle is in such overload or such strain that not only do we see diastolic septal flattening, we actually see it focally bowed throughout the cardiac cycle into the LV. You can see that in a slightly different respect here, the short axis at this level. This is really indicative of right ventricular volume and or pressure overload or strain. And then in these patients with chronic right heart strain or overload, they have a pretty classic LGE finding. So we're here at the base short axis. They typically have LGE at the RV insertion points. So as opposed to hypertrophic cardiomyopathy, which also just has a very different morphologic phenotype, the LGE was also insertional point in hypertrophic cardiomyopathy, but that tended to be a little bit more patchy, a little bit more blotchy. What we typically see here in RV pressure overload, again, usually the right ventricle is the more abnormal finding, but usually this tends to be a little bit more well-defined, a little bit more fine compared to hypertrophic cardiomyopathy insertional point enhancement. So just a couple last words about scleroderma versus sclerosis or complications thereof. Again, it can be with primary cardiac involvement, in which you can get, due to the scleroderma itself, right and or left diastolic or systolic dysfunction. LGE can be pretty variable, but the most classically, most commonly described involvement was what I showed, and it was mid-myocardial. But again, depending on kind of your patient population, and including our patient population, we usually see kind of more secondary cardiac effects of just severe pulmonary involvement. Again, that is right ventricular dilation with evidence of volume and or pressure overload. And LGE, you may not see LGE from scleroderma itself, but you might see LGE from chronic RV overload, which is typically that kind of well-defined insertional point. So that was a whirlwind, to say the least, of both ischemic and non-ischemic cardiomyopathies. Sorry, I went a little bit fast there at the end, but I wanted to be a little bit respectful of kind of our typical hour time slot. But just in a couple summary points, hopefully I've kind of convinced you that cardiac MR is a pretty powerful tool for both qualitative and quantitative analysis of just structure and function in general. Ischemic and various non-ischemic cardiomyopathies can be distinguished both based on morphology as well as enhancements, namely delayed enhancement patterns. And then I didn't focus too much on protocols, but just at least mentioning kind of different approaches and different protocols in terms of what's what's mandatory, what's nice but not necessarily mandatory, and what's certainly not going to provide you with information. I kind of sometimes say, especially with cardiac MR, which these exams can get very lengthy, is to choose and choose wisely. Or another way of saying that is just because you can do some of these sequences does not necessarily mean you should do all these sequences. And with that, I will close off my talk. Again, it was um, very nice being with you today. This was a great experience, and hopefully either I or other of our faculty member at Duke can kind of continue on with this lecture series. And with that, I'll pause and take any questions.
Thank you, Kevin. That was a awesome presentation. It looks like we have one question from the audience, from Amir, who asked, how do we evaluate all these different types of pathologies in areas where, cardiac MRI isn't as readily available?
Yeah, so unfortunately, yeah, it is with the assumption that cardiac MR is available. There is, in terms of just because cardiac MR, just to speak to cardiac MR in a little bit, or MR in a sense. I mean, if you have access to MR, but maybe not kind of typical part. So I kind of again approach this as kind of like fully loaded protocols, relatively more advanced sequences. There are continuously being kind of validated and tested more abbreviated cardiac MR protocols. So for example, I brought up things like multi-parametric mapping. Those are nice, but not necessarily mandatory. Again, from just more of a simplified cardiac MR protocol, as you probably saw, a lot of it just all you need is kind of SSFPs and functional information and late gait enhancement. That being said, of course, if you don't have MR, some of these things can be tough. I will make a plug. I can't fully endorse this because I think the data is still kind of forthcoming, but there is more and more data on applying some of these principles to CT. Granted, some of these will require kind of specialized CTs that can do cardiac imaging. So, you're essentially probably going to need gated cardiac CT or CT scanners with cardiac capabilities. But there is more and more research coming out too. So you can do function. If you do retroflectively gated CTs, you can do functional analysis with CT. It's not quite as good as MR, certainly not as good as echo, just given kind of temporal resolution issues. But there have been more and more kind of protocols or research kind of revolving around kind of the post-contrast capabilities of cardiac MR. So there's been research showing capabilities of stress exams with cardiac CT using a pretty similar protocol and a similar concept. And then there's been some kind of interesting kind of research and validation, kind of basically doing cardiomyopathy assessment with essentially kind of an LGE protocol. If you inject, iodinated contrast and really do cardiac CTs at the appropriate time, like 5 to 10 minutes later, you can potentially elicit subendocardial enhancement. You could potentially evaluate enhancement patterns due to non-ischemic cardiomyopathies. And then there's been more and more research of late with the concept of extracellular volume fraction calculated in a similar fashion as MR. Again, I know that's a lot of kind of research, and that also is predicate on having fairly advanced cardiac CT capabilities. Honestly, in terms of what I just mentioned from cardiac CT, while we do cardiac CT, some of the more like cardiac CT stress testing, LGE evaluation, we admittedly don't do that here, but that's not to say that won't become a little bit more streamlined in the years to come.
Great. We have another question. Deepa Kumar asks, is there any difference in cardiac MR protocol that's used for cardiomyopathies at 1.5 Tesla versus 3 Tesla?
So in terms of the general approach to protocols, I would say no. There are some sequence parameter adjustments that do need to be made. Admittedly, I don't do a whole lot, admittedly, really any hands-on scanning here. So I'm not kind of number crunching and kind of pushing the buttons and changing the parameters on the fly. So I can't comment, admittedly, too much in terms of TEs and TRs and things like that. What needs to be change 1.5 versus 3 Tesla. One kind of just from a more qualitative interpretive standpoint, if you do multi-parametric mapping, there is a significant kind of interpretive distance, or excuse me, interpretive thing to know is that your like native T1 values will be substantially different. They'll be much higher at 3T versus 1.5T. So if you're working on a 3T scanner or working on a 1.3T, 1.5T scanner, and you're kind of using reference values in the literature, just make sure, among other parameters, that your Tesla strengths are the same. I know there's a number of debates out there in terms of should you be doing cardiac MRs at 1.5 versus 3T. Again, the protocol shouldn't be changed, but there are issues with susceptibility artifacts a little bit worse at 3T. However, your signal to noise ratio is going to be better at 3T. That's an ongoing debate. I've been at institutions that prefer 1.5T. Here at Duke, we have both, but slightly prefer 3 Tesla. But from just again, the sequences, they should be available at both 1.5 and 3T, but there are some subtle parameter changes. But unfortunately, I don't want to say anything that's incorrect, so I won't comment any further on that.
Okay, it looks like we have another question. We have a participant that asks, is T2 star imaging still not recommended to be performed on 3T systems?
That's, to my understanding, it's still preferred at 1.5 Tesla, I believe. I think the underlying issue, again, is susceptibility and artifact issues with 3 Tesla systems. The one thing I don't know, personally, I haven't quite kept kind of abreast in terms of the literature of late on this. I know a lot of the data in terms of validation of T2 star times with regards to degrees of iron overload, I believe those have been validated at 1.5 Teslas. Always, if you are at a place that kind of does a lot of cardiac MR and 3T and you're doing T2 star mapping, I'm not saying it's impossible. Just do be careful in terms of your reference ranges that you're comparing to, reference ranges that use techniques similar to what you're doing.
I think that's all the questions we have. Thank you so much, Dr. Kevin Kalisz, for your time and expertise. And I think it was really awesome and an honor that Duke Radiology Residency got to participate in this program and share this lecture with you guys. Thank you, everyone, for your attention and participation.
And everyone have a great rest of your day, whatever time of day it is for you.